I know we didn't have to do slides, but Marissa did put a couple together just to give you all like a bit of an overview, or maybe you know a bit about the Health Connector, but just to give you a more rounded out version of all that we do. So that kind of, you'll have a little bit more context, and then we're going to save plenty of time, I think, for like a panel and discussion at the end. And also, just an FYI, Marissa is going to be joining us for the second half. So I think, we'll kind of go through this, and you can ask us questions, and then maybe Marissa some more once she joins us later. Great, we can go ahead. So again, just our overview. We are the state's official ACA health insurance marketplace. So we offer Massachusetts residents and small businesses a way to understand their health coverage options, access affordability, assistance, and compare and enroll different quality health and dental plans. And I think, people think of us as the place where individuals come, to get subsidies, and kind of forget what we do. And while majority of our members do get subsidies, there's also individuals who don't get subsidies, who just don't have other options for coverage, whether that be Medicare or Mass Health or an employer-sponsored plan, who come here and pay full price for their coverage as well. So a lot of, I think, variety and different audiences as well. So we were created in 2006 as part of bipartisan state health reform, aimed at increasing access to health insurance in Massachusetts. And then later we adapted and incorporated the federal health reforms of the Affordable Care Act. So our agency, the Health Connector, predates the Affordable Care Act and had a variety of plans in place, again, for individuals and small businesses pre-ACA. And then, of course, we became the ACA compliant exchange. And then, we kind of talked about who we serve, but kind of those three primary populations: low to moderate income residents through what we call our Connector Care program, and then middle to higher income individuals who are what we call unsubsidized and non-group, meaning they don't get any assistance paying and they're not part of a group or a business. And then, like I said, small businesses, which we define as less than 50 employees. And then sort of our primary objective is, to facilitate access to affordable health insurance for, again, individuals and small businesses. Exchanges were sort of designed to protect consumers in otherwise complicated health insurance markets. And basically, we're putting buyers and sellers of health insurance on more equal footing with better protections in place as well. So we, want to expand health insurance and coverage to all Massachusetts residents. We have a pretty good uninsured rate, but it's not zero. And so expanding coverage and trying to get to that zero number is always part of our mission. And then some of our strategic goals currently include advancing health equity by promoting robust coverage of services, affordable premiums and cost sharing, and improvements to of a broad range of services, providers, and different supports.
Thanks, Sarah.
Yes, I'm giving it to you, Kayla.
Okay. So Sarah gave us an overview of sort of those populations that we serve, and here you can just see sort of the breakdown of what those look like by program. So we have Connector Care, which is our flagship program. This program is for households with under or equal to 300% of the federal poverty level. And so this group gets both federal premium tax credits and state premium and cost sharing subsidies. So this group, we layer federal and state help to help them pay for coverage, not just premiums, but also those out-of-pocket costs. And so for 2023, plans have a guaranteed premium as low as $0 to $137, and that is sort of tiered with income. And we just we make sure that people have a certain cost plan available to them in their region. And we set those dollar amounts. And so members can choose from one to four plans in 2023, depending on the region they live in. Plans have no deductibles and low cost sharing. And to give you a sense of what 300% FPL means, we have some dollar amounts here for 2023. So you can see it's about $41,000 a year for a single individual and about $83,000 a year for a family of four. And so we also have, as Sarah mentioned, we have this group of sort of what we call subsidized members. So not the connector care crowd, but individuals who are only getting federal subsidies. So just federal help through the ACA. And let me just go back to connector care. Not every state has that type of program. So that's unique to Massachusetts. Sort of a holdover of what we had before the ACA. It's very cool and sort of our favorite thing about us. And other states are doing things like this, and we talk to them and we've helped them sort of create their own program. So that is sort of unique to our exchange. Less unique is this, these advanced premium tax credit individuals. These are households over 300% of FPL, and they would only be eligible for federal only premium tax credits. And so those help reduce the cost of health insurance purchased through us. And then again, we have that unsubsidized crowd who don't qualify for state or federal subsidies, but they choose to come to us because they can sort of use our exchange to make an apples to apples comparison. They know the coverage through us is safe, comprehensive, robust. We have certain requirements for carriers like network adequacy and requirements about coverage, and they have to meet all state and federal laws. And then our Health Connector for Business program, we have about 12,000 members. And again, that's for small employers with less than 50 employees. And there are certain benefits through our small employer program too that businesses can only access through the exchange. And so one of those is a small business tax credit created by the ACA. And so that's sort of one of the benefits small groups can only get through us. This is just to show sort of all the carriers that we offer. As you can see, like these look really familiar. It's always, I think, sometimes challenging for people to understand us as an agency. We get confused with Mass Health a lot, the state's Medicaid program. And so people don't usually think of us as sort of having access to all of these carriers that you typically think of when you think of insurance. But we are basically the front door to all of these types of plans. Individuals, families, and small business can access and compare among all of these types of plans and dental carriers. And then the other component to what we do at the Health Connector, there's this whole side of our agency that is involved in broader policy making and specifically related to the individual mandate. And so Massachusetts has required adults to maintain health insurance since 2007. So this individual mandate is really important to us in the state in promoting market stability, and it's the reason we have one of the reasons we have such a low uninsurance rate. I think it's about 2.4%, and that's down from other years. So we chose to keep our individual mandate in place as the Affordable Care Act brought a similar policy, sort of modeled after what we had. The federal individual mandate penalty is no longer being assessed. That went away as of tax year 2019, but our state mandate remains in place. And the Health Connector Board is responsible for a number of aspects of the individual mandate. So including affordability standards, minimum creditable coverage standards. So that means sort of the regulations that say what is minimum creditable coverage, what does it mean to have health insurance, what counts, what allows you to check that box on your tax form that says I had coverage. It can't just be anything, it has to meet certain standards. And so our board and our agency is in control of what that looks like. And then we develop hardship exemption criteria. Okay, and then we also, I won't go into too much detail here, but we use this process called the annual seal of approval process to review and approve qualified health and dental plans. So we require carriers to submit at least one standardized platinum, high gold, high silver, bronze, and catastrophic medical plan. Standardized plans are designed by the Health Connector staff. We have input from stakeholders, And those designs are really intended to enhance consumers' ability to make that comparison apples to apples when they're shopping. So that standardization really does help people when they're making their decisions. Plans must also, as I mentioned before, meet all state and federal requirements. So they have to cover essential health benefits, meet deductible and actuarial value rules, and MCC guidelines, or as I just mentioned, minimum creditable coverage. Plans are reviewed to ensure they meet all Massachusetts Division of Insurance standards and, again, all applicable state and federal laws. And so the seal of approval process is a big policy lever for us. We are able to sort of refine this every year and think critically about what changes would really help meet our policy goals. And so we just have 2 examples here. So the Health Connector required that all its health insurance products offer pen injector insulin at tier 1 cost sharing for 2022. And this was part of our one of our health equity strategic goals. We looked at what conditions were having a disproportionate impact on people of color. And so we wanted to make that the insulin delivery mechanism more accessible. And so that was one way we could do that. Connector care plans in 2023 newly include zero cost sharing for certain medications associated with chronic conditions as part of our ongoing health equity initiative. So again, we sort of pinpointed chronic conditions that were disproportionately affecting people of color and thought about how we could look at what those costs and sort of where we could change the cost sharing. And so those are just 2 recent examples, but you could see how that, that whole seal of approval process with the carriers allows us to have a big policy impact. And I will hand this over to Sarah.
Thank you, Kayla. Just to touch on a couple of our outreach initiatives and member supports. And this is the team sort of that I work on. So very near and dear to me. So we create sort of visibility opportunities in underinsured communities or communities that have higher numbers of uninsured individuals, while giving meaningful support to applicants and members, throughout Massachusetts. So, we like to do high visibility events, creative activities in these communities to promote what's available through us. For example, we advertise pretty heavily during the World Cup, knowing that, younger Hispanic males tend to have higher rates of uninsurance in Massachusetts, and that's a target population of ours that we could really reach through the World Cup. And so we spent money there to really get to them. We also created sort of a first in the nation partnership with the Mass Cultural Council, where we're giving members access to low cost and free admission to Cultural Council institutions across the state. So if you're a Connector Care member, you can get discounts at like a variety of different museums and different, activities there. So just like a member sort of perk for them. And then there's in-person assistance that we give individuals to help them enroll and keep their coverage. We have navigators. So we have 22 navigator organizations. We've got about 100, and it says over 100, but it's actually 145. This is my program, so I know. Members statewide. The navigator program is actually a required program through the ACA that exchanges have to administer. But, we really, I would say some states, they do it, everyone does it a little differently. I think we really invest in our navigator program and try to make it the best it can be. So, our 22 locations are in areas where there's higher uninsured rates, cities, places where we have high membership, where we know people really do need assistance. We pick trusted local organizations. They're helping members maintain coverage. They're providing public education. They're doing outreach and enrollment assistance and really doing the work to meet people where they are in their communities, speaking the language. really sort of our eyes and ears on the ground, and our true enrollment assisters on the ground, working with people. In addition to those navigators, which are grant funded and paid, we have certified application counselors who the state, with also in conjunction with Mass Health, certifies to be able to help or assist somebody do an application and enroll in coverage. So you'll see a lot of those application counselors at hospitals and health centers, or providers' offices, even at jails where people are maybe needing assistance or in transition, to help them access health insurance coverage. We have a customer service center or interaction center. We have 3 in Boston, Worcester, and Springfield, where people can get in-person support from our customer service sort of vendor. They can apply, process payment, do paperwork in person there. And then we do have, for our small groups, over 300 certified brokers who help small businesses sort of navigate our small business website and choose plans, health and dental for their businesses and for their employees. I think that brings us sort of at a conclusion of some of the work that we do. And I think, yeah, we'd love to take your questions. We can maybe kind of give a little bit of overview about like the areas that we work in more specifically, as I was kind of like alluding to. I'm seeing head nods, so maybe we'll start there. So I do have my MPP from Heller, but I actually work in the communications and outreach team. So I started on the policy team, but then moved over to the more so the outreach team. So my job is like I'm the navigator program manager. So I'm managing all the activity day to day, big and small picture for that community program, that outreach program. And I actually was an enrollment counselor, sort of like a CAC. They didn't exist back then, at a hospital, doing applications for uninsured patients at our hospital. Went to Heller, got my degree, got my master's. And then when I was at Heller, I did the Sillerman Fellowship. And that really opened my eyes up to grant making as a tool for policy. And then once I was at the Health Connector, started in policy, but then actually went back into that kind of space of grant work. So really have enjoyed, I think, the grant space, and understanding the grant space as a person with a policy background. So yeah, I sort of manage our selection of navigators. Every other year we select organizations, that whole process, reading grants, screening grants, scoring grants, all of that. And then just all the day-to-day of helping them train and certify, get ready for big things like this. I'm sure if you guys are following sort of health policy, there's the end of the protections, mass health protections coming up. So helping like our navigators understand what's happening, prepare, train them for that event, and really, get them all ready to better serve those people who are going to need to do renewals in this year. So that's just a little about me. I'll let Kayla say a little bit about your background and what you do for us.
Great. Thank you, Sarah. Okay, so like I said, graduated in 2018. I did the MPP and MBA. And before Heller, just for a little background and context, I worked for Senator Markey, and before that worked for then U.S. Representative Ed Markey. So worked on his campaigns, worked in his local offices, and then helped, was there for the Senate run. Then I went to Heller, and then after that, right to the Health Connector. So at the Health Connector, my title position right now is Associate Director of Policy. Our policy team is pretty small, but mighty, I would say. And
super mighty. Super mighty.
So much going on. So, some of the things that I work on, as Sarah mentioned, and I saw some head nodding, the end of Medicaid protections, that is sort of where our heads are at right now, and it has been for the last 3 years, because this is the most massive coverage event we've seen since the ACA passed. I'm sure a lot of people think of it in the mass health context, but there's lots of people who are now transitioning to us, and we have to be ready and make sure that we are serving those members in the right way, and we're doing whatever we can to make sure there's no gap. So that's an example of sort of a big breaking policy item. Constantly tracking federal regulations, proposed rules, litigation out of US district courts that impact the ACA and us. There's recently one on preventive services, a huge one, which we're still trying to sort of do a deep dive on and understand how will this impact our members. What have we done to sort of close gaps when federal policy breaks, and we try to do that ahead of time. And so the policy team does a lot of that work, sort of laying that groundwork so that if there's an administration change, we're not we're not leaving our members in a vulnerable position. So yes, we, state bill tracking, when laws pass at the state level, we have to think about, okay, so if this benefit is now required to be covered at $0, how does this change our plans, and what does that mean for us? Do we know, for example, what last year, or about a year ago, we had a law that required abortion coverage at $0 and related services. What does related services mean? And how do we work with our division of insurance to make sure that carriers are covering the right things at $0? And so all these policy changes, we have to think about how we put that in our system and make sure our members see those benefits. So I would say, we also work on surveys and work with outside researchers who are interested in looking at our data to write papers and do research on best practices. I spend a lot of time looking at other exchanges and thinking about what we could be doing better. Examples including like coverage programs for immigrants who have certain statuses. That's an area where we could do a lot of work. Something we're actively looking into. What have other states done? I'll tell you, New Mexico is doing something really cool. But yes, I'll stop there. That's sort of I would say the day-to-day is a lot of longer reports and also sort of like fire drill, fast-paced memos when there are federal or state changes. So it's a good mix of both of those things. I think that's everything, but I'll stop there, and I think we can open it up, and I would, love to take any questions and whatever you all are interested in hearing about.
I have to hop off in 3 minutes, but thank you for this presentation. I'm just curious for both of you, how broad was your understanding of health policy before you ended up at the Health Connector?
I can go first if that's helpful, Sarah. I would say mine was pretty broad. I had a really deep interest in the Affordable Care Act when it did pass in 2010. I had been interning for a member of Congress, still Ed Markey at that time. So I had sort of a lens into the process. I became really in love with the ACA and the possibility of, expanding coverage for people. So I think I might be an anomaly in that I was very into the ACA. But I also in undergrad had a really big interest in public health and global health. But I always found myself sort of coming back to the US healthcare policy because there was so much left that needed to be fixed and still needs to be fixed. Yeah.
I would say similar. I actually had a college degree, undergraduate degree in health policy and management. And then of course was doing application and enrollment assistance every day for several years, which really gave me a pretty good understanding of how policy was working in action. And, I really understood sort of the nuanced differences between Mass Health and the Health Connector. I knew about the ACA, was tracking kind of all of that. And then of course, once I was at Heller, sort of all of my work was focused around healthcare, and health systems. So hopefully that's helpful. But I also, I would say even if you don't have a really extensive background, but you are interested, it wouldn't, I don't think, preclude that, right? I think, our overall at the Health Connector, I think we have a lot of people with various different backgrounds, and a lot of different kind of roles and jobs too. So I think it's always something, if you're interested in it, that you could, pick up.
Yeah, I would totally agree with that.
Thank you for coming. Nice to meet you.
Yes, thank you so much. I look forward to watching the rest of the recording.
Great.
Thank you.
Sure.
So thank you so much for taking the time to come speak with us. This is really helpful. I was wondering if you could talk a bit more about the work that you're doing around immigrants, and kind of what New Mexico is doing. My capstone currently is actually about immigrants and mass health, and I've been meaning to look into the connector care on that front. So anything you can share on that would be fascinating.
Great question. And I know I see Marissa just hopped on. I can take this question after an intro maybe, or before, it's up to you.
Either way is fine. Hi, Marissa Woltman. It's nice to meet you. I'm sorry to be late coming from another meeting, but go ahead, Kayla.
Okay. Okay, well, welcome to Marissa. And so yes, that is a great topic. That sounds super exciting. I would say what we're doing right now is really just looking at other states. So I mentioned New Mexico because they had sort of this big health coverage package. It included a lot of different things, including something similar to Connector Care. As I mentioned, we stand out in that program. Not every state, and not, most states don't have an exchange with that state and federal subsidy program. New Mexico's, I think it's called the Immigrant Coverage Expansion Program, or just Coverage Expansion Program. They are designing it to look sort of similar to our Connector Care in the way we explained it, a little different, a little more, maybe resembles a small Medicaid program in some ways. It's sort of like an open bid for carriers to participate. The idea is that they would use Medicaid rates, but it would be run by their exchange, but it wouldn't be part of the exchange or the platform. It would be sort of adjacent to it. And there's lots of reasons for that. There are certain federal rules that wouldn't allow that. You can't use certain financial help, so, for a lot of different purposes, and I think for privacy and safety, feeling safe using that platform for that population, it's a good strategy. And so their estimates right now are looking at using Medicaid and Medicare rates to make that more affordable. It sounds like, based on their state budget, it may look, different depending on resources. It's unclear, but I, would be happy to send you anything I've found, if that would be helpful. And then the other states, I'm sure you may have already seen, would be Colorado and Washington. But yes, I would say at this point, we're just researching what other states are doing and hoping that we can do something actionable.
Thank you so much.
Sure.
I think I'm probably going to follow up questions, but I'm thinking.
Okay.
So if anyone else has any questions.
It looks like we had a question in the chat, but I'm kind of wondering, Marissa, we went through the presentation and then Kayla and I just kind of talked about like our specific roles and a little bit of kind of like how we got here. So maybe you could go through that for yourself and then we could answer the question in the chat, because I think that kind of comes as a nice natural next step to that.
Sure. Thank you for catching me up on where we were at, Sarah. So again, Marissa Woltman, I'm the Senior Director of Policy and Applied Research here at the Health Connector. I have been at the Health Connector for a long time. I joined in 2008, and I started by working on our appeals team. So helping people who were trying to qualify for our pre-ACA subsidy program, Commonwealth Care, as well as people who were facing a tax penalty under our state's individual mandate and who had financial hardships that they wanted considered. And so I worked on our appeals team for a few years and, really highlighted a lot of the spaces in our healthcare system where people got tripped up and places that we could improve. And so I ended up dropping to part-time and going back to school for my master's in public policy at Heller. And then when I finished school, went back full-time on the policy team rather than on the legal team. So have done lots of different things on the policy team, but I think have maintained that strong connection to that kind of member level policy thinking and member-centric approach. And we really run the gamut. I'm sure you heard from Kayla and Sarah, our policy team really spans from looking at statutes and regulations and political dynamics all the way down to the nitty gritty. What happens when you click a particular button, in our online application? What should those choices be? What should that verbiage be? How will people understand it? What if they don't understand it the way you think they do and they give you weird data that produces unexpected results? How do you get ahead of that? And then there's our whole research arm looking at how do we know if we're doing a good job? How do we compare to other programs, other states, our past experience and performance? What do our members think of our performance? How do we gauge that through survey work, et cetera? And then incorporating all that feedback to say, how can we make things better? I think one of the projects, I'm not sure if you guys touched on it, that I'm most excited about right now is our administrative burdens audit. So thinking about how taxing it is on people to have to apply for health insurance, go through all these questions about their family, their taxes, their income, just to get their health coverage, to have it change many times within the year potentially, versus someone who's on an employer plan where when they get hired, they say, yeah, sign me up. That's great. And then the employer takes care of everything and they don't think about it again for a whole year and it's not a problem. And when we think about, our membership, we have, a broader variety of, low or limited English proficiency members. We have a higher number of immigrants in our coverage, more people of color. It ends up being a racial equity issue that our application is so burdensome. And it's something that we've taken on to address. We've engaged a vendor to help us figure out where are all of those friction points in our process that from start to finish, it could be lots of different areas, not just, the application process, but the enrollment process, finding a doctor, all of that, where people are getting tripped up and slowed down and not really getting what they need. So I would say that's been a really big area of focus for us and a really driving motivation in a lot of the work that we do and thinking about how we can do it better. So let me stop there. I'm happy to take any questions on any of that, or Sarah, if you want to go to the question in the chat, we can do that too.
Sure. Why don't we start there and then we'll see if people have other ones. So this one I think would apply. We can all take our turn answering. What skills do we use most on a day-to-day basis? Oh, this is a good one. I can start. I really think just the ability to stay organized with multiple different projects. As you've heard, like every kind of all the things that we're responsible for and all the different fields of work, there's a lot that can be happening at once. And so just trying to really keep track of what are your deliverables and responsibilities. It really is, I think people think that maybe government, there's like this, I think especially among MPP students, there's this idea that government doesn't do anything or isn't working hard, but I think our agency works incredibly hard and there's a lot of different projects and there's so much going on. So really that ability to prioritize different projects is huge. And just different things, deal with different things that come at you. There can be like in one day, I'll be giving a presentation, I'll be working on a training, I'll be writing some kind of memo. I've got navigators emailing me about various issues that they're having with members, with staff, with access. So you can have just, I think every day is different and a lot of different priorities in the air. And I think just for me too, in my role, trying to just be dealing with people and really helping them to find solutions and grow their programs and pushing them or encouraging them to think about things differently and participate in different events. And so there's creativity and people skills and really time management and project management skills as well. Okay, let one of you all go next.
I'll go ahead. Yes to everything Sarah said. I won't take all of her answers, but staying organized and trying to pivot on a lot of different things at once that may all be equally important is super, that's pretty critical day to day. I would say one skill that I feel like I'm using on a daily basis is probably good old-fashioned policy analysis skills and specifically trying to nail down what is the question I'm trying to find the answer to, and really without getting lost in such a big topic or a big regulation or a big law or bill. There's so much noise in that, especially when you're interested in the topic or you're coming from a certain place and you're sort of reading it a certain way. Like, how do you just get into that and find the answers that really matter to the members and to our organization and for the correct functioning of our application and our system? So really just trying to keep the policy analysis skills forefront is something I think I do use every day or try to. Yeah, and also a good to-do list. Staying organized, like Sarah said, is so important.
I will attest that Kayla is a superstar of the one-pager on really complicated topics. I think that's something that gets honed over time, is writing really clear distillations of complicated topics for busy people, both I think in kind of written format and graphical format. Like we work a lot on like, does this graph make sense to people? Like not everyone can read a graph, and that's okay. But how do we kind of chew that for them? I also totally agree with Sarah on the interdisciplinary front. I think it's one of the things that I liked most about the policy space is I get to do, spreadsheets in the morning and presentations in the afternoon, and there's some good, reading in between. So I love that. One thing that I feel like has always stuck with me and that I do use a lot, we read a book in one of the management classes called Crucial Confrontations, I think. And I don't even know if it's still in the curriculum because it's been too long since I was there. But it really talked about the importance of like setting clear expectations and being able to communicate kind of without that emotional component, focusing it on the work. And I feel like that combined with just thinking about the different skills that everybody brings to the table and the different styles and approaches that are so helpful, and being able to really appreciate people and have them know that when you talk to them about a project where you might have a disagreement, I feel like is something that I took out of that text and that I definitely use all the time in talking with different teams and departments or stakeholders who have differing views, and has been really critical to being able to manage those relationships and processes successfully.
Happy to take other questions too, if you have any.
So I have another question. Of course, some policy changes have to go through the legislature, and then others you can sort of you can change through agency regulations and implementation. And it seems like from the description of some of your programs that some of them are kind of creative efforts to address issues that would maybe normally be addressed through legislation, but maybe aren't being addressed that way. If I was wondering, is that a fair characterization? And if it is, if you could talk about that a bit.
To start with that, I think we do have a decent amount of flexibility given to us in the statute and regulations, both on a federal and state level, to do some of these kinds of initiatives. I think there are definitely times where we need legislative changes, and we have worked to pursue those. A good example is a new checkbox on our tax form, our state tax form, that lets someone opt into getting information from us about insurance that was explicitly prohibited previously, and we were able to work to get that changed. But otherwise, you know, I feel like that's one of the most fun parts of what we get to do, right? Is kind of within the flexibilities we have, how can we shape a program that has the values that are important to us and to our members? So I think that that strategy is something we're always looking to do. Sometimes it's kind of proactive and sometimes it's reactive. You know, a good example of that is related to the federal government not paying cost sharing reductions any further. A few years ago, you know, there were kind of national level solutions where carriers charge higher premiums to get the money made up on the premium side. But I think that there need to be state level responses to that as well. And what can states do? There are lots of different options, and they all have pros and cons, but doing that kind of exploration and figuring out kind of what the clearest pathway is, and clearing that with other teams, right? Like legal may find that they're not comfortable with a certain approach without that legislative change, or maybe legal's okay, but operations says, whoa, we can't ever implement that, it's too crazy. So we do a lot of that interdepartmental work to say, how do we make something that's administrable and legal, and also checks the boxes for what it is that we're trying to promote through our coverage. I don't know, Sarah or Kayla, if there's anything you'd add.
Just from like my vantage point too, you know, I was explaining how I managed the Navigator program, and that is, you know, a required program in the ACA. There are regulations sort of outlining in broad ways how that program is supposed to work and the requirements, but there's a ton of flexibility too in how we administer that, how we fund it, you know, how much we want to fund. Is subject to the state budget. So, you know, if we feel that there's a need for more funding, that's something that we can propose and ask for. You know, then that's a huge one, right? And in terms of how much support is really out there in communities, you know, we can advocate for more if more is needed, or more is needed in a certain area. What we have them, you know, do in terms of outreach, or how they reach their communities, or their language capacity, how long we fund them for. You know, we fund them in 2-year grant cycles right now, but even that's something that we could fund for a longer period, you know, before we select again, or we can make it a shorter period. That's something at our discretion. So there's a lot of different ways that we can kind of mold and design that one specific program that is, you know, has federal regulation, but gives us a lot of flexibility to, I think, try to make the most of the program to help and serve the communities. And, you know, you could kind of see, you know, during sort of like the Trump era, there was funding for that program federally got taken way back, but because we run our own exchange, and we could set our own budget. So we could decide for ourselves what we wanted to fund and how much we wanted to fund, and in different communities, what might make sense. So I think that's kind of one example too.
Yeah, I would agree with all that. And the only thing I would add is sometimes, you know, there are things that are better suited for internal operational policies. or maybe like, we were talking about SOA or the seal of approval process as a policy lever when we did those intro slides. So sometimes, it doesn't make sense to put something in regs or open up the regulations. And sometimes it doesn't make sense to push for a state law, but we have other ways to do things. It can be tricky to figure out what the right path is, but not always.
So I had a quick question. So how could you talk a little bit about the size of the Health Connector and the organization of it at a more macro level? Because I wonder, it's a very MPP heavy crowd, but I also wonder if there are, what are some of the other groups that are represented?
Sure, I can take that. So we are all kind of nested within the policy and communications teams here. So there's kind of pure policy that Kayla and I tend to work on. We have our plan management team within that who handles kind of what our plan designs look like. And then there's the communications team that Sarah belongs to that incorporates all that navigator work, other kinds of outreach and education, press inquiries, member communications, what our letters say, things like that. We also have a large operations team, and they kind of manage two primary vendors that we have, one that does our call center and one that does enrollment and premium billing, kind of behind the scenes, making sure that when you go on our portal and click, I'd like to buy at this plan, that makes its way down to the carrier to say, please enroll Marissa in your coverage and send her a card. So they do all of the training and management of those vendors. And they also include our ombuds team for people who have escalated issues. They have a couple of people who work directly with our carriers to do, address issues that come up if those transactions aren't going over appropriately, or if there are other questions. Someone calls and says, oh, I've been in a coma and I missed open enrollment. Can I sign up retroactively, even though it's April? Those kinds of exceptional circumstance questions that might need a carrier to weigh in. They're kind of liaising with the carriers in that way. We also have our finance team. They handle both our what we call administrative budget, because we're not technically a state agency, we're a quasi public authority. So we have our own budget and funding that comes in as a portion of our premium revenue that we collect, and that funds salaries, our lease on our office space, all of that stuff. We also have our programmatic budget that is funded by a trust fund at the state level through tobacco taxes, surcharge on employers' unemployment benefits, and individual mandate penalties. So that's what funds our Connector Care program, and they work to manage that budget as well. We have an actuary who works on that team, who helps us with our plan and premium design as well as our budget. We have a legal team that handles everything from, again, kind of like internal HR, other kinds of contracts that we execute to do our business. They have the appeals team under them. And, again, any kinds of, escalated issues that might require some kind of legal advice, the navigator contracts that we execute, all runs through legal, and IT. That's the last one. So again, kind of bifurcated. We need a help desk. When my laptop breaks, we need people who do that, but we also have people who work with our vendors to manage these huge releases of functionality that go in on a periodic basis and make sure that people around the agency are reviewing and weighing in on the requirements and specifications there. And that's both for our non-group and small group work. And I totally forgot that the small group team belongs on operations, which don't tell Shaitra because I feel really bad that I always forget small group. But they're just a much smaller piece of what we do. So we do have that small group team as well that works with employers and brokers. So I think that's everybody. Okay. And I think we have like 80 staff total, just to give a ballpark.
We have a lot of external vendors, you know, like Marissa mentioning, you know, our contact center vendor, our payment and, you know, premium vendor, our web, you know, when you apply, our application is like a vendor. And so there's a lot of, that's our staff, but, you know, I'd say it's like branching out too into other organizations that are, you know, contracting with us to help us run.
Past to thousands.
So I don't want to detract from questions of the current students on the call, but when you ended with IT, it reminded me of some great conversations that we've been having at Heller about the role of technology, and specifically technology in government and in service provision. So, you know, we are bent out of shape about chat GPT, but I'm curious how technology is influencing or shaping the work that you're doing now, or, you know, what you see in the future, and how our students can prepare for that.
That's an interesting question. I feel like my gut reaction is that we have less of a problem with the cutting edge technology. We need to catch up, right? It can be really challenging given the size and scope of our technology platforms and the budget we have as a government agency to maintain that and enhance it, given, you know, changes to regulations all the time. But I think that's definitely something that we think about. You know, how do we make the most of what we have? But maybe, Kayla, I could throw it to you to talk about our research on algorithmic bias, because I think that it's a far more interesting intersection of our work with technology.
Yeah, I agree. That's where my mind went immediately. And yeah, my response is going to be like, we don't have technology, but that's not true. I'm just kidding. I just learned what Chat GPT was today. I read an article about it, so I'm catching up. But algorithmic bias is definitely an area that, as you know, an agency that works with carriers and provides health insurance, this is something that, you know, we are starting to look at more and try to sort of understand what our carriers are doing and what requirements are in place to make sure that there's not discriminatory algorithms in place. And so it's difficult because we're the agency, and then there's the health insurance carriers, and then there's the providers providing care. And so I think a lot of what's been covered in the news and these horrifying stories about the way algorithmic bias is happening, so the way care is being delivered in a discriminatory way, is on the provider side, which we're a couple, you know, pieces removed from. However, there are also, you know, our carriers have contracts with those providers, and then our carriers have algorithmic bias potentially, and how they distribute like care management, and do they use algorithms to decide how care management teams happen, and claims being accepted or not, and that is something that carriers, insurance companies use as a tool. And so we do, it's a little more difficult for us to have that reach. Like I mentioned, we have the seal of approval process, which is our main tool to sort of make policy changes when we're talking about insurance carriers. And we've seen other states do this, and they, you know, they're trying their best, but I think we've seen that it is difficult to reach the provider level, but we can reach the carrier level and say, you know, you shouldn't have algorithmic, you know, you shouldn't be contracting with providers who have algorithmic biases and the way that they're offering care. You should make sure that you're on top of that. And then, you know, one step closer to us, you should make sure that you're not using those algorithms in the way that you manage your care teams and things like that. I would say we have at this point, all we've done is really ask carriers if they're aware of any sort of discriminatory impacts of their algorithms and whether they've done an assessment, what they do to keep track of that. That's sort of where we're at. We're sort of in an information gathering place at this point. And I think this is an area where we've seen it in federal regs, proposed regs at this point on non-discrimination, sort of looking at this topic area and sort of asking, I think there was some request for comment on this topic area. It's, I think, something that we'll see more of and be working more of, but I would say at this point, it's sort of coming to our attention as something that we should play a role in and make sure that we're not exacerbating any inequities through those algorithms that carriers or providers might use.
I noticed that there's a question in the chat. It's from Bob Hitt. It says, apologies if this area was covered earlier, but what is the interface between Health Connector and negotiating with providers? So you kind of addressed that just now, but is there any influence outside of Mass Health?
No, but we have a ton of influence directly with providers. I think it's more through the carriers. We know that our carriers do tout Connector Care membership when they go to providers to negotiate their contracted rates and say, look, we serve this population. We know you want to serve this population too. Will you give us lower rates so that we can have low cost options for them? So we know that does happen, but it's generally invisible to us.
All right. Are there any other questions? Allison, yeah, go for it.
Yeah. Apologies for hogging you guys. Returning to the immigration thing, you mentioned looking at Colorado and Washington. I was wondering, is that referring to the state-funded subsidies?
That is referring to their immigrant coverage programs. So, yep, specifically. They do it in really different ways, those three states, along with New Mexico, and I think they have their own unique way they've approached it. So, okay. Interesting.
Thank you.
So, I don't know if you had any final words that you wanted to share, but I think it would be wonderful if you'd be willing to give your contact information, or if there are some websites that you would recommend that we pay attention to and that students pay attention to in terms of opportunities. I think that would be really helpful.
Yeah, absolutely. Happy to share contact information. I think, I don't know if it's easier to put it in the chat, or Jasmine, I know you have all of our email addresses. I'm always happy to chat with students anytime. Anyone can feel free to reach out.
Okay.
Yes, definitely. We can send that over.
Okay, super. Well, I would be happy to share your information. I have recorded this session, so then I can share it also with the students that attended and others who were not able to make it. So, but we really appreciate your flexibility. We had hoped very much to get out to your office, and it wasn't going to work, but I didn't want to reschedule. So thank you. And thank you, Marissa, for reaching out to Mike and offering, hey, there's a big group of people that are here that we would love to talk with current students. So we really appreciate it.
Absolutely. It's our pleasure. Please send Mike our best. And it was really great to meet you all.
All right, great. Have a wonderful weekend.
You too. Bye-bye.
Bye.
Bye.
Everyone.
Thank you.